So you have a 60-year-old female. She presents to your office with vaginal dryness, painful sex in 2018. She was diagnosed with an estrogen-sensitive tumor, breast cancer, and she is on anastrozole and is having trouble managing her vulvovaginal symptoms. So how do you counsel her? Well, vaginal estrogen is first line for genitourinary syndrome of menopause, but for those with breast cancer, it's more complicated. So we really only have observational data looking at the fact that the risk of recurrence is not increased. And this, although there have been studies looking at this specifically in the patients on aromatase inhibitors, it is, like I said before, observational data. And so I always talk to patients about that. Really unlikely that the risk of recurrence is going to be increased with low dose vaginal estrogen, especially if we start them out on once a week and then up it to twice a week and then up it to 3 times a week, because really the highest risk of systemic absorption is the beginning of treatment. And so if you're doing it very sporadically while you wait for the mucosa to heal, unlikely that there's really any significant systemic absorption. That being said, I start with non-hormonal options, and then I go through the same algorithm that I've already told you about. So number 1, minimizing irritants, avoiding that contact dermatitis of the vulva from all of these products and long name chemicals. You want to talk about moisturization, so single ingredient organic coconut oil, some of the hyaluronic or lactic acid products that you can check out, and then vaginal hormones. So vaginal DHEA, which is Interosa, has been studied in patients on aromatase inhibitors, vaginal estrogen, and even vaginal testosterone. Lubricants for sexual activity, you want to avoid gimmicks, fragrances, flavors, no more KY. There's a lot of chemicals in KY, so I do not recommend KY. There's also newer CBD lube products. The efficacy is kind of, debatable, like whether they're really significantly better than non-CBD products. So I just leave that up to patients, but I always counsel them that, CBD can be absorbed, and if there's any THC in the product, that could potentially change a urine drug screen. And if that's something that they need for work, then that could be problematic. You want to talk about referring these patients to pelvic floor physical therapy, and also you can refer them to the music program if you're in South Florida. So treating dryness, painful sex, and menopause is not just for breast and GYN cancer patients. So for lung cancer patients, focus on their vulvovaginal health and positions that minimize dyspnea. Colorectal cancer patients, hormone replacement therapy in young survivors, dilators, pelvic floor physical therapy, especially if they've had pelvic radiation. For these adolescents and young adult thrivers, you want to talk about education, safe sex practices. Don't forget about contraception for those patients, and really encourage LARC or long-acting reversible contraception. Sarcoma patients, you want to manage surgical morbidity to make sex functional and improve intimacy, even without penetration for some patients. And vaginal estrogen is really only absolutely contraindicated in advanced endometrial cancer patients. And so this is a book that I've actually read that's really helpful. I encourage it to a lot of patients. I read it in about a day. It talks a lot about getting to know your new body after treatment, even though it has the word disability in the title. I tell patients to try not to think of it that way, but there are some really great tips in here, especially for patients who are thinking of getting back to dating and et cetera, and want to be safe about that. So what I don't recommend, vaginal steaming or vaginal detoxes, anything that's basically on the Goop website, including jade eggs, any homeopathic remedies like vaginal yogurt, tea tree oil, or garlic, anything that's a feminine wash. Jade eggs, like I said before, are an expensive piece of jade that the Goop website tells you to place in your vagina, and that can actually make pelvic floor muscle dysfunction worse. So I don't recommend lasers like the Mona Lisa Touch for patients on aromatase inhibitors. The systemic estradiol levels in those patients is so incredibly low that the healing is disrupted in the vulva and the vagina. And given that the efficacy of these lasers is really based on creating a lot of microscopic injury, given that healing is disrupted, they have an increased risk of having things like burns, scarring, or worsening pain. And so I do not recommend lasers for patients with a history of on aromatase inhibitors who have really severe vaginal atrophy. The FDA has actually asked these companies to really scale back their marketing as vaginal rejuvenation. Vaginal rejuvenation is a marketing term, it's not a medical term. And so, patients who are going through normal menopause without a history of cancer, this might be an option for them, but most patients, I'm just waiting for long-term safety data. Caution with surgical cures, these labiaplasties and mommy makeovers that are being promoted, sometimes these things can put patients in a place where they're worse off than they were before, with scarring, et cetera. You just want to make sure that you have someone doing these procedures who has a lot of experience with the varied anatomy that these patients have after treatment.